Okay, Assalamu alaikum everyone. I'm Bushra Rasheed. I am an intern, and today I'm going to be giving you guys a small practice review session on pathology. I'm covering all of the lectures of pathology under POD 231, the course. And I really hope that you find this lecture helpful. Just a few rules I'd like to establish before we start. If you'd like me to stop at any point in the lecture, please let me know if you have any questions. If you feel like the answer isn't clear enough, you can stop me. At the end of the presentation, I've linked my email and my phone number in case you'd like to text me if you have confusions or doubts, or if you'd like to email me. Okay, these are the resources that I've used. So I used Amboss. Amboss was the primary actually resource that I used. I find it very helpful. I feel like it's helpful preclinical, clinical. It's helpful forever. I really do think if you're able to get the subscription, I would highly recommend. I also used BRS Pathology. They have a good review session, and then they do questions at the end. And then Pathoma and the lecture slides, of course. All right. Now you're probably looking at this slide and you're thinking, what the heck? What does most common mean? I want to tell you something about Dr. Oban's slides. So you know the last 4 lectures that he taught, the neoplasia lectures? He has a few points mentioned in the lectures that say like most common site of cancer metastasis, most common site of blah, blah, blah. It's related to neoplasia, of course. And he likes to bring them in the exam a lot. For our POD, I think this was like 3 or 4 years ago when I gave my POD exam. But for our exam, he brought I think 4 or 5 questions. And this is like very low yield things. And it's stupid marks if you memorize it. So I really want you guys to memorize it. I've basically compiled everything in this lecture, so you can just look at these and memorize it from here. So from the neoplasia 2 lecture, the most common site for hematogenious spread of cancer would be the lungs. Hematogenious spread is, of course, spread through the blood, right? And the lungs are want oxygen, you want to, lungs, it makes sense. Lungs are very heavily perfused. And so hematogenious spread of cancer, the first site that it occurs to would be the lungs. The most common site for seeding of malignant cells into body cavities is the peritoneal cavity, just because it's so expansive. The most common site of bony metastasis is in the vertebral column. The most common symptom of bony metastasis would be pain. And the most common type of cancer that causes osteoblastic or radiodense metastasis is prostate cancer. If they've given you a picture of an X-ray and you're looking at the bone and it seems like the bone is more dense in one of the regions, that would be radiodense. That would be osteoblastic. And the most common type of cancer that will give you this kind of a metastasis would be prostate cancer. This is the last 2 lectures. The most common type of malignant lymphoma would be the follicular lymphoma. Most common radiation-induced cancer, leukemia. Most common leukemia associated with IR is CML, which is chronic myelogenic leukemia or myelogenous leukemia. And then lastly, the most common paraneoplastic syndrome is hypercalcemia. Paraneoplastic syndromes in general are very high yield, and I would recommend that if you're able to, like go over this topic a little bit before your exam. The 2 most common causes of this hypercalcemia would be the release of PTHRP, which is PTH-related peptide. So it's basically this molecule which is released by 2 specific cancers, so the renal cell carcinoma and squamous cell carcinoma of the lungs. And it's this molecule that looks like PTH, so it kind of works like PTH. And we know what PTH does, right? It increases the level of calcium in your blood. It does that by reabsorbing more calcium from the kidneys. It reabsorbs more calcium from the GI, like from your food. And it also causes breakdown of bone to release more calcium, and that is how hypercalcemia comes about to be. Lastly, osteolytic metastasis also causes hypercalcemia. I feel like that's pretty self-explanatory. When there is some sort of a cancer that's invading bone, it's breaking down the bone, and so more calcium is released into the blood. So yeah, these 2, I would highly recommend that you memorize these because Dr. Aban's gonna bring them. He's definitely gonna bring them. And it sounds like it's very low yield, but he likes to test on this, so I would recommend that you memorize them. All right, moving on to the first question. A 64-year-old woman is brought to the emergency department 30 minutes after the onset of right-sided weakness and impaired speech. On admission, she is diagnosed with a stroke, and the treatment, this isn't really important for you guys, but basically, yeah, she has a stroke and she has these symptoms, okay? A CT scan of the head shows hypoattenuation of the territories which is supplied by this particular artery. Which of the following processes best explains this finding? So basically what's occurred is a stroke, right? There's some sort of an abnormality that's occurred in the brain. And what kind of necrosis do you think occurs in the brain?
Liquefactive?
Yes, perfect. Liquefactive necrosis. Would you be able to explain how?
I think Because the structure of the brain is like have lipids or something, so it's not like the
Mhm.
heart or the kidneys that like it will be coagulative.
Perfect. Yeah, exactly. So the brain has the cells of the brain, the neurons are very rich in lysozymes or lysosomes. So what ends up happening, and the brain is a very spongy material to begin with, right? It's super soft. So what ends up happening is that when the lysosomes, when they release their enzymes, it like dissolves the brain and it's this liquid sort of material. And yeah, that's pretty much what happens. And this is mostly by the neutrophils. That's the point that you should definitely make sure you know. Yeah, that's pretty much it. So again, the stem of the question is not necessarily very important. What's important to note is that we're talking about the brain, and we want to know what kind of necrosis occurs in the brain, and we know that it's liquefactive. Okay, exactly. That's what it looks like here. So in the first around 72 hours, the neutrophils move in, they release their lysosomes and digestive enzymes, so the entire area of the brain gets digested. And then the macrophages move in, they remove cellular debris, and that is why this tissue is no longer brain tissue, right? And that's why it appears on CT, it appears hypoattenuated, which basically means that it appears lighter in color because there's less brain tissue here, right? So that makes sense. Next question. A 38-year-old man is admitted to the hospital because of fever, jaundice, and nausea for one day. He recently returned from a backpacking trip in Brazil, during which he had a 3-day episode of high fever that resolved spontaneously. 5 hours after admission, he develops dark brown emesis, anuria. What does dark brown emesis mean? Like, what does it indicate?
Esophageal bleeding.
Yes, exactly. So it indicates upper GI bleeding. Other words for dark brown emesis can be coffee ground emesis. This is another word which can also be used in place of this. Anuria means that he is not urinating, right? Despite life-saving measures, he dies. Postmortem liver biopsy shows eosinophilic degeneration of hepatocytes with condensed nuclear chromatin. These hepatocytes were most likely undergoing which of the following processes?
Necrosis.
Okay. I thought it was necrosis too, actually, initially, but it's actually not. It's apoptosis. Do you think you would know why? Okay, I don't.
Eosinophilic.
Sorry?
Eosinophilic.
Yes, yes, that's one of the things that gives it away. So the fact that it's eosinophilic, of course, degeneration, there's condensed nuclear chromatin. And the fact that the entire cells are the fact that it's eosinophilic, we know that they're very, very dark pink, and that happens when the cell sort of shrinks down. We know that we're talking about shrunken cells rather than cells that have ballooned up, and we're not talking about any sort of inflammation. Maybe if this was necrosis, they probably would have also mentioned that there were neutrophils in the area, there were macrophages in the area, there's lots of inflammation that's going on. But we know that apoptosis is self-programmed, right? It's programmed cell death. It's something that the cells decide to do themselves. And so there's no inflammation. There won't be any neutrophils to the side. It's something that cell does by itself. So yes, eosinophilic would give it away and condensed nuclear chromatin as well. Okay. A 22-year-old woman comes to the physician because of pain and swelling of her left foot. 3 days ago, she cut her foot on an exposed rock at the beach. Her temperature is 37.7 degrees Celsius, which is high. She has a fever. Examination of the left foot shows edema around a fluctuant erythematous lesion on the lateral foot. And you don't really need to know fluctuant, blah, blah, blah. That's not necessary. What's necessary is that there's it's erythematous, it's red. Which of the following is the most likely primary mechanism of the development of edema in this patient? Would anybody like to guess? Take a
Uh,
guess. It's fine if you're not right.
think
That doesn't
it
matter.
is inflammation. So
Mm-hmm.
maybe maybe the first one.
The
No,
first one.
not the first one. Sorry. The second is it increased capillary hydrostatic pressure.
Okay. Would anybody else like to say anything before we look at the answer? Okay. So the answer is actually E, separation of endothelial junctions, and I'll explain to you why. Let's go step by step. Let's look at the first option first. Fluid production by the bacteria. I feel like that's not very like that's very unheard of, right? I feel like I've never really read anywhere that the bacteria are explicitly producing fluid in such a short amount of time. So I feel like we can rule that out because it doesn't sound right. The second one, increased capillary hydrostatic pressure. I understand where you're coming from, but this would not be right because this has to be more of a systemic thing. For example, if we have a patient with congestive heart failure or right-sided failure, they have increased capillary hydrostatic pressure overall. So this is more of a systemic thing. This would not be localized. And the edema in this patient is very localized, and it's after she got a cut. So this would not probably be the answer, right? Decreased plasma. Does that explain it? Does that explain why B would not be the answer?
Yes.
Okay, I'm glad I was clear. Decreased plasma oncotic pressure, that happens when you don't have enough proteins in your blood. Either you're losing proteins because of some renal syndrome, or you're not making enough proteins because of a liver abnormality, which again, those are systemic issues. And this patient's issue is only that she had a cut on her foot. So that doesn't make sense. Systemic cytokine release, that too is systemic. It's not local, and this patient's issue is local. Her edema is local. So we would not consider this. Systemic cytokine release would also present much more drastically. It might present as shock. You know, cytokines have been released in the entire body. All of the vessels in our body have vasodilated, and now all of the blood is pooling in the veins and arteries, and none of it is going to the heart to get pumped. So that would present much more drastically or dramatically. It wouldn't be something as small as just edema on the foot. So the answer is separation of endothelial junctions. How does that happen? When you get a cut, when you first get a cut, you get hurt. Mast cells are released, right? Mast cells get activated. What happens then is that they degranulate, they release histamine, and we know that histamine is one of the most important factors for causing increased vessel permeability. That ends up happening through the separation of endothelial junctions, and so more fluid leaks out. That's what causes edema. Along with fluids, we know that because there's blood sort of accumulating in the area, the area is hot, the temperature is hot, which is a defense mechanism against bacteria. And we know that the inflammatory cells have left the blood vessels and leaked out because of the separation of these junctions. And that is how we are able to control the microbial the microbes in the area. Yeah, I hope that explained it. Moving on. 4 days after admission to the hospital for acute pancreatitis, a 41-year-old man develops hypotension and fever. His temperature is 39 and the pulse is high, 115. The normal pulse or the limit of the pulse should be 100. This is over that. The blood pressure is low, 80 over 60. The first thing that should come in your mind when you see this, when the pulse is high and when the blood pressure is low, immediately you're thinking of shock. These two, this combination together, blood pressure low, pulse high, is shock, okay? Physical examination shows warm extremities and blood oozing around his IV sites. Whenever you see the word blood oozing from his venipuncture sites, blood oozing from the IV sites, this is very, very pathognomonic or very, very indicative of DIC. Okay? The moment you see that there's blood oozing from these sites, think DIC. There's numerous small red non-blanching macules and patches covering the extremities, as well as large ecchymoses. His hemoglobin is 9, which is low. A peripheral blood smear shows schistocytes and decreased platelets. Again, you don't need to know this. I will explain it to you, but it's not necessary for your exam. Which of the following sets of serum findings are most likely in this patient? So the answer is C. DIC, let's talk about what DIC is, first of all. DIC, disseminating intravascular coagulation, is basically when it's a consumptive coagulopathy. What that means is that you're using up all of the clotting factors. The clotting cascade has gotten activated. We're using up the platelets, we're using up the fibrinogen, sorry. We're using everything up and we're making tons and tons of microclots or microemboli. What that does is that depletes the body of clotting factors. So now, even though you literally have clots, you're in a hypercoagulable state because you don't have clotting factors, you don't have platelets anymore, or they're less actually. And because of that, you're more likely to bleed. So if I was to explain the question from a DIC perspective, first of all, we have shock, right? Not necessarily indicative of DIC, it's more the blood oozing around his IV sites. The fact that he has large ecchymoses means that he's bleeding. There's some sort of bleeding occurring. That's why he has these large bruises. And the same goes for these patches and macules. When TAC occurs and the microemboli get lodged in the dermal capillaries, the dermal blood, obviously, blood flow stops, and then might present with these kind of symptoms. You can see that the hemoglobin concentration is really low because there's so many clots occurring now. And schistocytes means basically damaged red blood cells. They're like blood cells that have been chopped in half almost. And this occurs because of clots. Because of the mechanical sort of when a clot bumps into the red blood cell, it might cleave half of it off, and that's why you would see schistocytes. And of course, decreased platelets, we know that because they've been used. Now, how is the answer C? Like we just talked about DAC and how the clotting factors get used up. So when there's no clotting factors, the bleeding, the PT and the PTT would increase, right? Because now you are at a more increased risk of bleeding. The fibrinogen would decrease. Why? Because the fibrinogen is all converted into fibrin for the clots, and so the fibrinogen is low. And lastly, the D dimer is increased. D dimer is basically I would say the end product or the metabolic product, not metabolic, but the byproduct of clots. So when a clot breaks down, D dimer is released. The more clots you have, the more clots sort of get broken down, I guess, and then the more D dimer you would have, right? So the PT is increased, PTT is increased, fibrinogen goes low because it's all consumed into fibrin, and then the D dimer is increased. Does that make sense for you guys?
Yes.
All right, perfect. If you feel like it doesn't, you can stop me anytime, okay? Again, I feel like I've explained all of this already. So there's going to be thrombosis, there's going to be hemorrhage, organ dysfunction because of the secondary to platelet consumption, and exhaustion of clotting factors. Organ dysfunction can also occur because of hypoxia because the microemboli are going to get lodged into the capillaries, into the blood vessels, so the organs might not be perfused properly anymore. This can lead to sepsis, which I feel like is what was happening in our patient. The fact that his temperature was high, his blood pressure is low, his pulse was high, indicates septic shock. Other clinical findings would include abnormal bleeding from his IV sites, for instance, organ failure, thrombosis, thrombocytopenia, increased D-dimer, increased APT and PTT, and then decreased fibrinogen. That's pretty much it. Management, I feel like is too advanced for you guys, but basically you would just stabilize the patient because of course they have hypotension, right? So you want to administer IV fluids to stabilize the patient because you don't want them to die on the table. Start urgent treatment of the underlying cause. In this case, we had sepsis, so we would administer broad spectrum antibiotics. And then yeah, administration of blood products. Again, this isn't really necessary for you guys. As long as you understood the question, you're good to go, inshallah. All right. An otherwise healthy 23-year-old man comes to the physician because of a 3-day history of mild persistent bleeding from the site of tooth extraction. He has no prior history of medical procedures or surgeries and no history of easy bruising. He appears well. Vital signs are within normal limits. These are the laboratory investigations. Let me just give you guys the normal limits. So the PT normally should be around 11 to 14, and the PTT should be 25 to 35. So this is normal and this is elevated. Which of the following factors do you think is deficient in the patient?
Factor 7.
Yes, exactly. Factor 7. Perfect. Would you like to explain why?
Because factor 7 is part of the extrinsic pathway, and the
Exactly.
extrinsic is by prothrombin. Sorry,
Exactly.
it's measured by
Perfect.
prothrombin.
The PT. Yeah, yeah, that's perfect. That's all you really need to know. All right. 2 days after undergoing internal fixation of a displaced right femoral fracture, a 34-year-old woman develops sudden shortness of breath. On examination, she is oriented only to person. So she's a bit disoriented. This tells us that there's some neurological symptoms, right? The shortness of breath tells us there's some pulmonary symptoms. Her temperature is high, so she has a fever. Pulse is super high as well, 122. Respiratory rate is also elevated, and then the blood pressure is hypertension. This is hypertension as well. Pulse oximetry on room air shows an oxygen saturation of 83%. This is very, very low. The normal oxygen saturation should be 95 or above, okay? There are several scattered petechiae on the anterior chest wall. Her hemoglobin is 10, which is also low. Leukocyte count 9,500 is okay, and the platelet count is 140,000, which is low, okay? Which of the following is the most likely cause of her current condition? So it's actually fat globules entering from the circulation. Now, the entire thing develops or the entire thing occurs because the patient had a fracture and they fix it, right? And this is 2 days post-op. What happens with fractures is that we know that there's a lot of lipids in the blood, right? The bone marrow is basically primarily consisting of lipids. When there's a fracture, and the bone marrow might get exposed to the blood, so the lipids might leak out. And large concentration or a large amount of lipids in the blood is not normal. And so they form like these fat globules, or they form like emboli. So this is basically a case of fat embolism, where these emboli have formed and they are causing, so she's not oriented, so she has neurological symptoms, right? So the fat emboli might go to her brain and they're causing some stroke-like symptoms. They might be lodged in the respiratory system. They might be lodged somewhere in the pulmonary arteries, which is causing all of these pulmonary symptoms. And then if the emboli get lodged in the dermal capillaries, you're going to see petechiae, right? Yeah, and the platelet count is decreased, which is what's showing us that there's clots or there's emboli going on. Yeah, all right. A 38-year-old man comes to the physician because of a 2-year history of cough and progressively worsening shortness of breath. He has smoked 1 pack of cigarettes daily for the last 10 years. Physical examination shows contraction of the anterior scalene and sternocleidomastoid muscle during inspiration. This part would be a bit advanced for you guys, just forget this line. But basically an X-ray of the chest shows flattening of the diaphragm and increasing radiolucency of the lower lung fields. Further analysis shows increased activity of an elastase that is produced by neutrophils. These cells, aka the neutrophils, were most likely stimulated to enter the site of inflammation by which of the following substances?
So they're asking us for chemotactic.
Yes, exactly.
D.
Indeed, perfect. So leukotriene B4. Can you give me more examples of chemotactic substances?
Interleukin 8.
Mm-hmm. Do you know
And
any other?
the and also the neutrophil degraded products.
Mm-hmm. Yeah, that's one.
And C4, no, wait, hold on, C5A.
C5, and that's the one that I was looking at the entire time. You know what's so funny about this question is that I got this on my step 1 exam. So this question is very dear to me. And I really wanted to include this. So yeah, chemotactic factors are very, very important. I guess high yield to know. And the most important ones would be leukotriene B4 and C5A. These two are super important for you guys to know. All right. 7 days after undergoing bilateral total knee arthroplasty, a 65-year-old man comes to the physician with a dark discoloration and blisters on his abdomen. He was put on low molecular weight heparin post-op. His vital signs are within normal limits. Examination of the skin shows blisters, with areas of necrosis around the umbilicus. Laboratory studies show a platelet count of 32,000, which is extremely low. The normal platelet count is 150,000 to 400,000, and 32 is very, very low. Which of the following is the most likely underlying cause of the patient's symptoms?
Is it C?
It is C. Yes. Would you like to explain why?
It is heparin induce something.
Thrombocytopenia?
Yes.
Exactly. So this is just a very classic presentation of somebody who's undergoing heparin-induced thrombocytopenia. This occurs usually hit occurs within 5 to 10 days of administration of heparin. This is 7, so this is perfect, right on the mark. And there's areas of necrosis, there's some discoloration and blisters, and then the platelet count is super, super, super low right after heparin. Um, this is very, very easy. I feel like you can easily tell that this is heparin-induced thrombocytopenia, and the pathogenesis of that is that heparin binds with platelet factor 4, and sometimes in certain patients, there's antibodies formed against this complex, and this will cause consumption of all of the platelets, and then all of the different blisters and the discoloration that you see. Okay, next question. An investigator is studying intracellular processes in muscle tissue after denervation. A biopsy specimen is obtained from the biceps femoris muscle of an 82-year-old woman who has sustained sciatic nerve injury. Investigation of the tissue specimen shows shrunken cells with dense eosinophilic cytoplasm, nuclear shrinkage, and plasma membrane blebbing. Which of the following best explains the muscle biopsy findings?
Is it B?
Release of mitochondrial C. Yes, it is. Do you want to explain?
The cells are dying by apoptosis. So,
Mm-hmm.
yes, in cytochrome C, it is the intrinsic pathway, which is the mitochondrial pathway, right?
Yes, yes, perfect. So overexpression of BCL2 would not be the answer. Why? Because BCL2 is the one molecule that's responsible for inhibiting the release of mitochondrial C. So overexpression of this molecule would actually be anti-apoptotic, which is not the answer. Degradation of BCL2 associated X protein. No, this wouldn't be the answer either. Denaturation of cytoplasmic proteins, inhibition of the Fas-L interaction. Again, Fas and Fas-L is the extrinsic pathway of apoptosis. By inhibiting this, it's anti-apoptotic, which definitely would not be the answer. Just as a quick overview, on top of this, so if you have some sort of a stress, DNA damage, whatever, it could be cytotoxic therapy, pro-apoptotic proteins get activated, right? And they go and activate the BAX or the BAC molecule. This causes the release of cytochrome C from the mitochondria, and then those would activate caspases. Now, these caspases could be proteases, which are responsible for breaking down the cytoskeleton, right? For apoptosis, that's necessary. These caspases could also be endonucleases, and those are responsible for breaking down the DNA. And that's when apoptosis occurs. Apoptotic bodies, like small, basically the cell releases small apoptotic bodies, which are taken up easily by macrophages through phagocytosis. And this is exactly how inflammation does not occur, because apoptosis is one cell and there's lots of small blebs that are going to come off of it. The macrophages are just going to take them up, and there's no cytokine release, no inflammation, no neutrophils, nothing. So this is apoptosis. Okay, next question. A 24-year-old woman comes to the physician for progressively worsening episodes of severe crampy abdominal pain and non-bloody diarrhea for the past 3 years. Examination shows mild distension, generalized tenderness, and there is a fistula draining stool in the perianal region. Immunohistochemistry shows blah, 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 NOD2 receptors. In vitro studies show that the receptor is usually involved in activation of the innate immune system in response to certain pathogen-associated patterns, also known as PAMPs. Which of the following proteins is most likely to be produced upon activation of this receptor?
NF kappa B.
Yes, NF-kappa B. So basically, the NOD2 receptor is basically a kind of PRR, which is a pattern recognition receptor. These are responsible for looking at PAMPs. What are PAMPs? They're pathogen-associated patterns. Pattern means there's some sort of a molecule that these receptors are familiar with that they can quickly attach to. What are some examples of PAMPs? Would you guys happen to know any?
LPS.
Not like receptors, lipopolysaccharide.
Yes, exactly. So LPS would be one of them. Peptidoglycan would be another one. Flagellin on certain bacteria would be one of these. So the moment these PRR receptors recognize these PAMPs, they bind to them, and upon the binding, they release NF-kappa B. And NF-kappa B would then release interleukin-1, it would release interleukin-18, and then these cytokines would then, recruit neutrophils, recruit macrophages, and they're going to come to the area to destroy the bacteria that was recognized, right? Okay. Next question. A 3-year-old boy is brought to the physician for a follow-up examination 5 days after sustaining a forehead laceration. Examination shows a linear, well-approximated laceration over the right temple. The wound is clean and dry with no exudate. There is a small amount of pink granulation tissue present. Microscopic examination of the wound is most likely to show which of the following. Basically, what they're asking is that there's granulation tissue, and they're going to do what does microscopic evaluation of the granulation tissue show? Basically, what does it consist of?
A, A.
Yes, exactly. Perfect. So, granulation tissue is basically what? It's fibroblasts secreting lots and lots of collagen. And then within that area, there's going to be certain angiogenesis, right? Just going off of this topic, would you guys know any growth factors that are responsible for angiogenesis?
Vascular endothelial growth factor and fibroblast growth factor.
Yeah, perfect, perfect. So these are the most important growth factors responsible for angiogenesis. Macrophage infiltration wouldn't really make sense because this is 5 days after the laceration. And this is something that would occur before granulation tissue formation, right? Capillary dilation with neutrophil migration. Again, this would be right after the child got the wound. This would not be after granulation tissue um, production. Acellular tissue with type 1 collagen. Nope, that isn't right either. What do you mean by acellular, you know? And then fibroblast hyperplasia with disorganized collagen deposition. That's not granulation tissue. Granulation tissue is pretty much very organized. And A makes the most sense out of all of these options. So yeah, let's go over the phases. So we have the inflammatory phase, the proliferative phase, and the maturation phase of wound healing. What happens in the very beginning, within the first 4 to 5 days, is that there's going to be edema, there's going to be erythema, inflammation, and pain, right? This is because the moment you get a cut, we have mast cell degranulation, histamine release, increased vascular permeability, and then that causes edema, that causes erythema, that increases the temperature of the area, that causes all of these inflammatory cells to come to the area. Healing process is triggered, and the immune system works to prevent microbial colonization. Then what happens is the proliferative phase, and this is where you're healing the area. So this lasts for around 20 days, okay? And this is basically where granulation tissue is going to get produced. We have fibroblasts, which are laying down the collagen. We have the edges of the wound, which are going to begin to contract, begin to come closer. And the epithelial cells migrate from the wound margins so that we can have a good approximation between the wound margins. And lastly, the maturation phase. This can last a very long time depending on how big the wound was. But basically so this is when the wound is completely filled in, completely strengthened, and this is exactly where the scar tissue forms. All right, next question. A 30-year-old man comes to the physician for a follow-up examination 1 month after sustaining a chemical burn over the dorsum of his right hand and forearm. Physical examination shows hyperextension of the hand at the wrist. The skin over the dorsum of the wrist is tense, and there is a thick epithelialized scar present. Range of motion is very restricted. The patient's contracture is most likely due to the activity of which of the following types of cells?
E.
Wait, so are they asking what causes contraction of the wound?
Mm-hmm.
Myofibroblasts.
Yes, exactly. So let's look at this picture right here. So we have the edges of the wound right here, right? And then these cells you see here, these are myofibroblasts. Now, as the name suggests, myofibroblasts have some sort of a muscle component to them. That's why it says myo, right? And the most important function of muscles is to contract. So these myofibroblasts are present only in the periphery. And once granulation tissue is getting laid down, these myofibroblasts would contract to bring the edges of the wound closer together so that, we need less granulation tissue to fill the gap. And that's pretty much it. Yeah, the growth factors, collagenous. We've talked about everything else here. Um, and yeah. All right, next question. A 63-year-old woman comes to the physician because of a 6-month history of fatigue and shortness of breath on exertion with 1 month history of ankle swelling. Examination of the lower extremities shows bilateral pitting edema and ankle edema. Pedal and ankle edema. Pedal means foot. Ankle edema would be a bit higher up. Cardiac examination shows a widely split S2 that varies with respiration, and the ECG shows right bundle branch block. Which of the following is the most likely etiology of the patient's lower extremity edema? Which one do you guys think is the
D.
answer?
And A.
Let's look. So it's actually D. Let me explain to you guys why. So we have a patient who's coming to us with swelling. There's ankle
Is it-
swelling.
Is
Sorry?
the congestive heart failure?
Yeah, that's exactly what this is. So we have a patient that's coming with edema, right? That's coming with edema, that's coming with swelling. And now you're seeing that there's some cardiac symptoms. It's not really necessary for you guys to know what a widely split S2 means. You don't really need to know for this block what a right bundle branch block would mean. But I feel like you can pretty much kind of tell, you can infer that because there's certain cardiac symptoms and now there's edema, you can kind of tell that yes, there's most likely congestive or right-sided heart failure. And that leads to increased capillary hydrostatic pressure. It's through the mechanism where, because there's heart failure, the heart isn't pumping blood out efficiently. Now what happens is the blood is kind of there's a backload of blood. There's venous congestion. There's blood that's pooling in the venous system, right? Which increases the pressure. The hydrostatic pressure is now high, which forces the fluid out into the interstitial space, and that is how the edema comes to be. Another sort of, I feel like something that adds on to this would be because there's heart failure, the heart is not pumping out the blood sufficiently to all of the organs in our body, right? So the kidneys are not getting perfused properly. When that happens, the kidneys are like, oh, I'm not receiving enough blood. I'm either in a state of hypotension or shock or whatever, and you know what? I need to be perfused properly. What they're gonna do, the kidneys release RAS. They activate the RAS system, which is renin, angiotensin, aldosterone system, which again is not necessary for you guys to know right now, but what you do need to know is that the kidney releases molecules that increase fluid accumulation, right? Because the kidneys are perceiving a lower blood pressure because there's heart failure. There isn't blood going towards the organs. The kidneys are like, okay, there's I'm I'm gonna reabsorb more fluid, more water from the kidneys to increase the pressure, to increase the blood pressure. And so this worsens the edema. And so this is kind of like a cycle that sort of occurs where you have heart failure, the kidneys aren't receiving, they're not getting perfused properly, they're releasing these substances which cause more water retention, which just makes the edema worse and worse. And so this keeps going on and on until they're, medicated or whatever. They go to the doctor and they're like, I'm having these symptoms, blah, blah, blah. Okay, next question. A 57-year-old woman is admitted to the ICU for management of shock. Her pulse feels feeble and her blood pressure is very low, 86 over 45 millimeters of mercury. The patient undergoes pulmonary artery catheterization, which shows an elevated left ventricular and diastolic pressure. Which of the following additional findings is most likely in this patient? Now, let me just explain to you what that kind of means. So, a left ventricular and diastolic pressure is when is the pressure in the left ventricle right before systole occurs. So, at the end of the diastole, at the end of the blood collection within the ventricle, what is the pressure that occurs right before contraction occurs? That's elevated. Um, Something important that I want you guys to note is that even though there's technically more blood or more pressure in the heart, the blood pressure is really low. So that blood pressure is not getting transmitted. The blood is not able to act it out. What do you think the answer is here? I'm giving you guys kind of hints because the question is a bit difficult. What do you guys think is the answer?
Could it be? It's either C or D.
Okay, would you like to choose one of them? Keeping in,
Uh,
keeping in
okay. Let
mind
me.
the
I don't think it's C since release of endotoxin isn't really here. So
Mhm.
I think it could be D.
It is deep. Perfect. So let's go over the options one by one. Cold skin due to loss of intravascular fluid volume. This would occur in hemorrhagic shock. This would occur in hypovolemic shock, but the patient isn't bleeding. The patient doesn't have hypovolemia, so this is not the case, right? Bronchospasm due to excessive histamine release. Now this would more so indicate anaphylactic shock. There's no sorry, I feel like there's nothing that they're indicating in the question that would tell you, oh, anaphylaxis might have occurred. Anaphylaxis is usually like the patient's just sitting perfectly fine. They all of a sudden can't breathe, and now they're coming to the ER because of bronchospasm. So that's not the case here. Mottled skin due to release of endotoxin. This will occur in sepsis. So this would be the mechanism of action for septic shock. And for sepsis to occur, there has to be either fever. You guys know the SIRS, right? The systemic inflammatory response symptoms, the things that occur in sepsis, and none of these are present here. So we're not thinking of sepsis, we're not thinking of endotoxins. And so naturally, we're thinking confusion due to decreased stroke volume. Why is there a decreased stroke volume? So let me just quickly explain it to you according to the question. You have a lot of blood pooling into the heart at the end of the diastole, but none of it is getting pushed out, right? What does this show? A decreased stroke volume. And so what kind of a shock would this be?
Cardiogenic.
Exactly. This would be cardiogenic shock. Perfect. All right. Moving on to the next question. A 12-year-old girl is brought to the physician by her mother 2 hours after cutting her hand while playing in the yard. Examination of the right hand shows a 2 centimeter laceration on the thenar region of her palm with some tenderness and erythema. The right palm appears mildly swollen in comparison to the left. In response to this patient's injury, the endothelial cells lining the blood vessels of the affected area express increased numbers of cellular adhesion molecules. Which of the following mediators is most likely directly responsible for the described change?
F.
F. It's actually interleukin 1. which is okay. Let's talk about why. This is more so a direct recall question because what happens is that wait, let me just hold on. Sure if it's yeah, okay. Sorry, I had to confirm. Okay, so what ends up happening is when you have any sort of injury, as is the case here, and you have histamine release and you have all of these other inflammatory cytokines that are being released, interleukin-1 and TNF-alpha are the most important ones that are being released. What this is going to do is increase the CAM molecules, cellular adhesion molecules. This promotes rolling and adhesion of the neutrophils, and then they're going to be able to marginate and get to the area of where they need to be to prevent microbial colonization. So the answer is interleukin-1. This is more of a recall question, I would say. I feel like this might be mentioned in one of the tables in your slides. Um, so yeah. Right here. So we have the sialyl-Lewis X-modified glycoprotein. It's going to get attracted to the P-selectin and the E-selectin. And how these P and E-selectin come to be in the first place, how do these molecules get attached to the endothelium, is through cytokines released by the macrophages, TNF-alpha and interleukin-1. So then the sialyl-Lewis X binds to both the P and E-selectin, rolling starts to occur, and then that's where, integrin would bind to ICAM, and then margination would start occurring. This is adhesion. And then margination would occur, which is when they're going through the blood vessels right into the extracellular matrix or extracellular space to perform the duties of, fighting the microbes, etc. All right. Next question. A 70-year-old man comes to the physician because of right-sided back pain, red urine, and weight loss for the past 4 months. He has smoked 1 pack of cigarettes daily for the past 40 years. A CT scan of the abdomen shows a large right-sided renal mass. Biopsy of the mass shows polygonal clear cells filled with lipids. Which of the following features is necessary to determine the tumor grade in this patient? Somebody answered in the chat. The answer is C. You're right. So would you like to explain why it's C? Why the degree of mitotic activity matters? Okay, let's talk about it. So basically, they're talking about grading the tumor, right? So what are the most important things let's talk about what grade is in a tumor. Grade is basically how well differentiated the cells are. So what that means is how, like liver cells, these tumor cells, how close to the liver cells do they look like? If this was to occur in the kidneys, how close to the natural kidney or the actual kidney cells do these tumor cells look like? The closely they resemble the actual organ cells, the more well differentiated that they are, and that just means that they're actually not that bad because they're very close in appearance to the actual organ, right? Poorly differentiated or a worse grade would be when the cells do not, they look nothing like the organ that they originated from. This is a very poor prognostic factor. This is not a good thing at all. And this usually happens when the cancer cell has evolved so much that it just doesn't even look like its original organ anymore. And that's what tumor grade basically is. The things responsible for looking at the tumor grade, number one is yes, the degree of mitotic activity. That's one of the things that we're looking at to see how well differentiated the cells are. Other things include nuclear pleomorphism. So does the nucleus look like the nucleus from the original organ or no? Does it look completely different? Is it a different size? Is the NC ratio completely off? Etc. And lastly, the cellular organization. So if you were to have a glandular organ or a tubular organ, do they still look, is the overall architecture of the organ or the tissue maintained or not? These are all the things that are necessary for knowing the tumor grade. The rest of the things mentioned on the slide, the size of malignant proliferation, invasion of the structures, location of metastasis, regional lymph nodes, all of these are staging. These are responsible, or we need to know these for the tumor staging, not necessarily for the grading. And staging includes TNM, tumor, lymph nodes, and metastasis, and that's what the rest of them are more so for staging. All right, next question. A researcher is studying the ability of breast cancer cells to metastasize. Neoplastic cells obtained from 30 patients with stage 4 ductal carcinoma of the breast are tagged with a fluorescent antibody. These cells are then inserted into a medium resembling normal human tissue. After 2 weeks, all samples show in vitro hematogenous invasion and migration away from the original site of insertion. Which of the following properties is most likely responsible for the ability of these neoplastic cells to metastasize to different places?
E.
E. Perfect. And why do you think it's E?
Because NMPs, they are alongside type 4 collagenases, they allow the cells to metastasize.
Yeah, exactly. So basically, how would you differentiate between a benign versus malignant tumor is the ability to metastasize, right? A malignant tumor can metastasize and can spread all over the body, whereas benign tumor would not metastasize. That's the integral difference between the two. Now, how would you know whether something has metastasized or whether it has the potential to metastasize is through invasion of the basement membrane. If the basement membrane is still intact, it's a benign tumor. It could be a carcinoma in situ, there could be dysplasia, there could be, but all of these would still not be malignant. There still wouldn't be potential to metastasize because the basement membrane is intact. Now, the moment that the tumor cells have released a metalloproteinase, which we know is a kind of collagenase, it's going to break down the basement membrane, and now the cells are able to metastasize completely. They can go where they can spread wherever, they can spread through the lymph nodes, they can spread through blood, through other routes. But basically, yeah, the basement membrane is the most important or the most integral part of knowing whether something has metastasized or not, and metalloproteinase would break down the basement membrane. All right, next question. A 16-year-old boy is brought to the physician because of a lesion that has been growing over his jaw for the past several months. He recently immigrated from the US to the USA from Kenya with his family. Physical examination shows a 3-centimeter solid mass located above the left mandible. There is cervical lymphadenopathy as well. That means that the lymph nodes in the neck are swollen. Diagnosis of Burkitt lymphoma is made. Which of the following mechanisms is most likely directly responsible for the malignant transformation of the patient's cells? Okay, we have an answer. A. Absolutely. Yep, it's A. So let me just quickly go over why it's A. I have a diagram here. So basically, Burkitt's lymphoma is characterized by a translocation. What does translocation mean? It means that one part of a chromosome has been swapped out for another part of the chromosome. So they've both exchanged bits, okay? The translocation for Burkitt is 814. What does that mean? So we have chromosome, can you guys see my mouse?
Yeah.
Okay, perfect. So we have chromosome 8 and we have chromosome 14, right? Chromosome 8 has the CMYC on it, and 14, this region or this gene codes for antibody chains. So there's heavy chains. Antibodies have parts, there's heavy chains, light chains, blah, blah. What you need to know is that it's coding for a part of an antibody. And usually the thing with antibodies is that they're continuously being produced, right? Our white blood cells are continuously looking at different pathogens, they're continuously producing antibodies. So this is in a region that is very heavily transcribed. It's heavily transcribed, it's heavily translated, and then these proteins are found in abundance in our body. What ends up happening in patients with Burkitt lymphoma is that this area and this area, they switch. Now the CMYC is in this spot, and then the antibody coding gene is in this part. It's on chromosome 8. Now the CMYC, it's actually a proto-oncogene. What does that mean? A proto-oncogene, this one specifically, is responsible for the proliferation of cells, for the growth of cells, for the multiplication of cells. And so when the CMYC is in a region on the chromosome that is heavily transcribed, there's going to be lots and lots of proteins that are made that are going to promote the proliferation of cells, that are going to promote the growth of cells. And because of that, we now have a tumor. And this tumor manifests usually around the jaw. That's where the Burkitt lymphoma usually manifests. And yeah, that's pretty much the explanation of how what a translocation is and what exactly happens. So the answer is activation of transcription, and this would be CMYC. So CMYC would just be transcribed and transcribed over and over again. Okay, next question. A
So
44-year-old man.
so CMYC is a transcription factor.
c-Myc is no, it's not a transcription factor. It's a gene. A proto-oncogene specifically. It produces molecules that I think it produces some molecules that are responsible in the cell cycle, like how fast the cell cycle goes. So basically, um, it's in a region that is transcribed. So you can think of it like some chromosomes or certain genes have molecules that are kind of covering the gene itself, so that transcription does not occur to block transcription, right? What ends up happening is that this region, because this is where the antibody chains were, it was transcribed the body needs it to be transcribed a lot. So there is no such sort of molecule, there's nothing on the chromosome, on the DNA itself, that's stopping the transcription. So once this exchange occurs, now c-Myc is in a region where transcription naturally occurs a lot. Our body knows that this is where heavy chains are supposed to be. So they're just continuously transcribing the gene and producing the proteins that are, that are produced by the gene itself. And these proteins are actually certain I think they're, yeah, cell cycle. They're responsible for stopping the cell cycle or initiating or speeding it up. And so what ends up happening is that the cell cycle ends up going over and over, like it happens over and over again. And cell cycle is responsible for the growth of cells and for the development, as in multiplication of cells. So the cells increase in quantity, and that's how a tumor cell comes to be, basically. Did that answer your question?
Yes, thank you.
You're welcome. I'm really glad I was able to help. So a 44-year-old man is brought to the emergency department with 30 minutes after being involved in a high-speed motor vehicle accident as a restrained driver. Physical examination shows dark bruising and discoloration over the right upper quadrant of his abdomen and right flank. The abdomen is tender to palpation. A CT scan of the chest and abdomen shows injuries in the right lobe of the liver. An emergency partial hepatectomy is performed. An ultrasonography on follow-up examination 6 months later shows that the liver has grown back to almost its original size. Microscopic examination of the newly formed liver tissue is most likely to show which of the following findings. Okay, somebody answered in the chat. The answer is D, you're right. Why is there normal hepatic tissue? So the liver we know has a regenerative capacity. We know that the liver is able to regenerate. How? We have stable hepatocytes and they're present in G0. G0 is the state where, there's no multiplication, no division, nothing that's happening in this state. What ends up happening is the G0 cells gets pushed to G1. You guys are aware of the cell cycle, right? Like you've taken it before in mole?
Yes.
Okay, perfect. So yeah, so the stable hepatocytes are going to go from a state of G0 to a state of G1, which is where they're now active. And this is where the cells would start regenerating, and we're actually forming new hepatocytes. It's not that we're forming granulation tissue, it's not that we're forming any other kind of, fibrotic tissue. This is actual liver tissue. This isn't, just fibroblasts, anything inflammatory related. Nope. No regenerative nodules. This is normal hepatic tissue because the liver has the ability to regenerate. Okay, next question. A 59-year-old woman is admitted to the intensive care unit after surgery following a motor vehicle collision. She has received a total of 4 units of packed red blood cells. Physical examination shows dry mucous membranes and flat neck veins. Serum studies show a creatinine of 2.1, and urine microscopy shows granular muddy brown casts. An renal biopsy specimen is obtained and examined under light microscopy. Which of the following reversible cellular changes is most likely to be present in this patient?
Swelling of mitochondria.
Swelling of mitochondria. Yes, perfect. So, yeah, so swelling of mitochondria is reversible. Pretty much all of the other things mentioned on this slide are actually irreversible. Fragmentation of the nucleus, no. You're not gonna be able to form a new nucleus once fragmentation has already occurred, right? It's not reversible. Rupture of lysosomes, again, once lysosomes have ruptured, the enzymes, the digestive enzymes are released. They're gonna break down the cytoskeleton, and the cell is pretty much gone at this point. Release of cytochrome C, we just talked about this earlier, but again, once this is released, this activates caspases, which would activate like proteases, endonucleases, and the cell is destroyed. Degradation of cell membrane phospholipids, so once the cell membrane breaks apart and everything sort of leaks out, the cell's gone. And the same goes for the dissolution of the chromatin. So yes, swelling of the mitochondria, swelling of the cell, swelling of the rough endoplasmic reticulum, all of these sort of swelling things only are reversible, but once ATP is depleted, once there's ischemia or hypoxia, ATP is depleted, sodium potassium ATPase pump no longer works, sodium starts to accumulate within the cell, water follows into the cell, so the cell has swollen. All of this is reversible. But the moment this stuff occurs, after this, everything that occurs after is irreversible. So yeah. Okay. A 40-year-old woman dies after a long history of an illness characterized by dyspnea, orthopnea, hepatomegaly, distended neck veins, and peripheral edema. Would anyone be able to tell me what these symptoms indicate? What disease did you think she has?
Congestive heart failure.
Perfect. So she has congestive heart failure. The cut surface of the liver as it appears at autopsy is nutmeg liver. The second panel shows the microscopic appearance of the liver. Which of the following disorders is the most likely cause of these findings? So this is what a nutmeg liver sort of looks like. There's pale areas, there's areas that are a bit darker, and this is what it would look like under a microscope. We already kind of talked about this, but yeah, right-sided heart failure or congestive heart failure would cause this. Basically, when there's congestion, so right-sided heart failure causes a backflow of blood, right? Because the right side is unable to pump properly. So in the venous system, there's a backflow of blood, there's congestion of blood. This causes congestion of blood within the liver as well. And so this is how it manifests. When there's congestion of blood, you can see that there's areas that are super red, but then there's areas that are pale that are not getting perfused properly. And this is what it looks like. It's called nutmeg liver. Okay, next question. A 38-year-old man with a 700 pack per year smoking history presents to the emergency department with shortness of breath and hemoptysis. Portable chest radiography demonstrates a large mass centrally located within the left lung field. The serum calcium level is 13, and the normal range is anywhere from 8.5 to 10.2. The metabolic abnormality described here is most likely due to elaboration of which substance? Okay. Somebody said E. Somebody said E. You're right. It's PTH related hormone. Would you be able to explain how it's E? Okay, I'll just quickly go over it. So basically, this patient has lung cancer, and it's centrally located within the lung field. We know that because we know about the paraneoplastic syndromes, we know that one of the paraneoplastic syndromes is hypercalcemia that occurs because of PTHRP, which is caused by squamous cell carcinoma of the lungs. I also went over it briefly in the beginning of the lecture. But yeah, so basically, the patient has lung cancer, which releases PTHRP, which causes an increase in the serum calcium through lots of different methods. There's more reabsorption from the kidneys, from the GI tract, and also we're resorbing bone. That's how we're secreting calcium into the blood. Erythropoietin would be paraneoplastic for renal cell carcinoma. So renal cell carcinoma secretes more erythropoietin, and it causes polycythemia vera, but it's like secondary to yes, it is considered a paraneoplastic syndrome because the cancer itself directly isn't doing anything to the calcium. It's releasing something, aka the PTHRP, and it's through the PTHRP that we have the hypercalcemia. So this is, yes, it's considered to be paraneoplastic. Carcinoembryonic antigen, CEA, this is more colon cancer related. I feel like it's not that necessary for you guys. So we can move on. Okay, 86-year-old man with a history of recurrent UTI infections presents with fever, tachypnea, tachycardia, mental obtundation, and reduced blood pressure. Which of the following forms of shock does he have? If you look at the question, first of all, the fact that he has fever, the fact that he has a reduced blood pressure, and tachycardia. So when the pulse is low and the blood pressure is high, this combo should immediately tell you there's shock. Okay, there is shock in this patient. Next, there's fever. And whenever there's fever with shock, I feel like you can easily say that it's septic shock, right? So what is it? It's septic shock. And septic shock is usually occurs secondary to some sort of an infection, right? In this case, it's a urinary tract infection. So what ends up happening is that you have gram-negative bacteria. They produce LPS, lipopolysaccharide, and what this does is that it causes activation of neutrophils, macrophages, all of these inflammatory cells, which release cytokines, and these cytokines cause mass vasodilation. It causes vasodilation of all of the vessels in your body, all of the arteries, the main arteries, and because of that, the blood pressure goes really, really low. And so it's shock, but in this case, it's septic shock because it's because of endotoxins, it's because of LPS. All right.
Does anaphylactic shock have fever?
Anaphylactic shock, I think it's not necessary for it to have, from what I know, I don't think it does actually. Anaphylactic shock. Let me just confirm and I'll let you know at the end of the presentation. But from my knowledge, I don't think so. I know because for sepsis, fever is one of the prerequisites. You need to have fever for sepsis, right? And so for
Yeah.
septic shock, obviously there is going to be fever. For anaphylactic, let me just get back to you, okay?
Okay, thank you.
Of course. Okay, this figure illustrates the microscopic appearance of the heart of a 56-year-old man who died after a 24-hour hospitalization for severe crushing chest pain, which was complicated by hypotension and pulmonary edema. What type of necrosis is this?
B.
Coagulative.
B, perfect. Would you be able to tell me how it's B? Like what from the image is giving away that it's B?
I guess heart that gives off coagulative.
We still have the architecture of the heart. It's not like dissolved like the brain before.
True, that's a good point. And the fact that the cells are super pink, they're hypereosinophilic, shows that this is necrosis, right? And the nuclei are not present. You can see the nuclei in the surrounding cells, in the surrounding myocytes, but there's no nuclei present here, or even if it is, it's mostly crushed, it's mostly fragmented or condensed. And so this shows us that yes, this is necrosis. And because it's the heart, it's coagulative necrosis. And as you said, it's not liquefactive because the architecture is maintained. All right, I think this is our second last question. A 60-year-old man with unstable angina, which is a form of acute coronary syndrome, has treated with intravenously administered glycoprotein 2E3A inhibitor. The mechanism of this action is the ability to do which of the following?
D.
Yes, somebody said D in the chat. You're right, D. And how is that? This is a diagram that would explain that pretty well. So we have glycoprotein 2B3A. It's right here. We have fibrinogen in the middle, which sort of links the platelets together. And we can see that 1B is responsible for adhesion to the endothelium. This is the endothelium. But 2B3A is responsible for aggregation. And so the answer for this would be inhibit platelet aggregation. Okay, I think this is our last question. Let's go. A 68-year-old man has a long history of prostate cancer that was metastatic at the time of diagnosis. Over the past 2 months, he has had significant weight loss of appetite, and loss of energy. His current spectrum of conditions can be attributed to which of the following factors?
TNF.
Yes, TNF. Perfect. So TNF alpha is the factor that's causing the cachexia in this patient, in this cancer patient. We know that vascular endothelial growth factor is responsible for angiogenesis, so that's not going to be the answer. We know that the platelet-derived growth factor and the fibroblast growth factors are responsible for wound healing. They're responsible for producing collagen by the fibroblasts and also increasing the amount of fibroblasts themselves. And interleukin 2 is just an inflammatory cytokine. It has nothing to do with the cachexia that's involved with cancer. Oh, that's pretty much it. We're done with the questions. This is a QR code for feedback. If there's anything that you'd like me to improve on, or if you have, if you just want to say some nice things about me, I would love to hear anything that you have to say through the form that's linked to the QR code. So please make sure that you scan this and rate the session. I would appreciate anything that you have to say, be it constructive criticism, be it, words of appreciation, and everything. And that's pretty much it. That's all from me. Good luck on your exam. I hope inshallah you guys do really, really well. And I hope that my session was beneficial. This is my contact information at the end. If you'd like to text me for confusions or anything, I'm available anytime. Inshallah.
Thank you
Good
so
luck on your exam.
Thank you so much.
You're welcome. You're welcome. Have a good day, you guys.